Welcome to this session concerning Fontan physiology and what we have learned over the last 50 years concerning this intriguing circulation. I have no disclosures on this presentation. Francis Fontan performed his first Fontan operation in 68 and reported it in 71. And as you may look at this cartoon of his original operation, I think most of you realize that nowadays we do it quite differently. So indeed, over these 50 years, many things have changed. I wrote my thesis in the late 80s on Fontan, and I will discuss what I was taught in those days. But after a couple of decades, I will tell you at the end of this presentation what I nowadays teach. What I was taught in those days was that a Fontan operation was very complex cardiac surgery that needed to be done by the best cardiac surgeons because the result frequently was unpredictable. Indeed, after such operation, the ventricle appeared frequently to be big, dilated, and dysfunctional. The afterload and systemic vascular resistance was shown or believed to be highly increased. There was a clinical picture of heart failure with the dysfunctional ventricle. So obviously cardiologists would go for their heart failure strategies with the four variables we all know very much. The golden formula of cardiology was applied, where cardiac output was known to be the result of stroke volume multiplied by heart rate. And so all efforts were there to increase and or at least maintain the stroke volume. And we try to excel in treating failure by improving that Fontan circuit at any possible level. So as cardiologists, that's what we did, being convinced that the heart was the center of the circulation. But after quite a couple of years, many of us are still frustrated. Why? Well, we have learned that many of these heart failure strategies don't work. Increasing contractility didn't give the result we had hoped for. Heart rate didn't work. Decreasing afterload didn't work. And we are almost unable to direct or to control the degree of stroke volume. So in order to better understand the disadvantages of the Fontan circulation, I think it is important that we first understand the major advantages that you have having a biventricular circulation. This is a cartoon of a typical biventricular circulation. We have both two ventricles, the left ventricle, the right ventricle, and normally the left ventricle will pull blood from the left atrium and push it into the aorta. That pressure, that energy will be lost throughout the systemic vascular resistance. The blood will be collected in the right atrium, and there the right ventricle will then pull the blood from the right atrium and push it into the pulmonary artery, where again this energy is lost in the pulmonary vascular resistance, and then the circle starts all over again. Typical for this circuit is that at rest it functions at 100% of normal, and with exercise a trained person can increase it up to 500%. RA pressure is lower than LE pressure. There is pulsatility, and typically all our patients are well saturated. Here the cartoon of a typical current Fontan circulation. We only have one ventricle, and so this ventricle will take the blood from the atrium and push it in the aorta. And instead of losing all this energy in the systemic vascular resistance, no, we will keep some of this energy in the caval veins, connect them to the pulmonary arteries, and use this energy for the blood to go through the pulmonary vasculature. We now know that the output in such a circuit is always decreased at rest. It varies between 50 to 70% or even a little more than normal. But with exercise, then it becomes obvious that it's significantly decreased. The central venous pressure, by definition, must be high because it provides the energy for the blood to go through the pulmonary vasculature. in the current circuits, there is no pulsatility or almost no pulsatility. And depending whether there is fenestration, yes or no, the patient will be nearly fully saturated or mildly desaturated. Now, what happened over here is that the surgeon, if you look at from the ventricular level, did put this pulmonary vasculature like a dam upstream in front of the ventricle. And this dam here will create what every dam does, upstream congestion and decreased output. Here you see a typical picture of a dam, the dam with the two features, upstream congestion, here the lake, and so that may be very enjoyable, but our patients don't appreciate that much that degree of congestion. And a dam also will control the flow and usually almost invariably decrease the flow downstream. In this case, very good to avoid floodings and things like that. In our patients, however, the decreased cardiac output will be cumbersome. The dam can be used for electricity, like in this case, or in our patients, the dam will be used for oxygenation of the blood. So what does this mean then in output? If you have here exercise level at rest, a normal person will have 100% at rest and will be able with exercise to increase it up to almost 500%. Our best Fontans will have a slightly decreased output at rest and will be able to increase their cardiac output, but they will never reach the levels of exercise that you can obtain with a biventricular circulation. That was for our best Fontans. Our worst Fontans will have a significantly decreased output at rest, and with exercise, they will be able to increase only slightly their cardiac output, and their exercise level will be markedly reduced. So the concept of excessive damming pretty fast came by. And if you have excessive damming, you will have a significantly decreased output, which will result in premature death, pronounced exercise intolerance, and also the development of pulmonary collateral flow. That excessive damming also will result in excessive congestion with edema, liver dysfunction, lymphatic dysfunction, and also some cyanosis, which is a different ballgame. Now, as clinicians, if we didn't like the result of the Fontan procedure as performed by the surgeon, we have the possibility of performing progressive undoing. But allow me to walk you through this slide. As a patient, a good patient goes from Glenn to Fontan, his ventricular output will decrease. In a patient with a poor Fontan, we will see that output will significantly decrease to levels that are barely viable. The saturation, however, in either patient will significantly increase. It will both increase in the good Fontan and also in the bad Fontan. However, another price to pay for that is the central venous pressure in the good Fontan will increase slightly. In the bad Fontan, it will go well over 20 millimeters of mercury, and that is a border of which we know it is very, very poorly tolerated. Now, if we don't like this result, we can progressively undo that, and that's what we call a fenestration. And theoretically, you could go for a fenestration for 0% to 100% of flow through the fenestration. And what does this mean for your patient? Well, immediately your cardiac output will increase to nearly normal levels. So that is very good. Similarly, your central venous pressure will decrease significantly, and central venous pressure, the caval veins, will be able to function at ventricular filling pressure. Very good. However, the price you will have to pay for this is a pronounced desaturation. And especially for the bad Fontans, it will be very steep down. And this may result that in a good Fontan, you have a very good compromise between output saturation and congestion. And then in the bad Fontan, whatever fenestration you will apply, you may never find an acceptable, clinical acceptable compromise between these three variables. But before we go on, let us first ask a few basic questions, because that is extremely important when managing Fontan operations. First basic question is, can you create a Fontan circuit without touching the ventricle? Well, I think by now everybody will know that connecting the caval veins to the pulmonary arteries, the surgeon can do that completely without even touching the ventricle. The Fontan operation nowadays has become an extracardiac operation. It is actually vascular surgery. There is no necessity for extracorporeal circulation. Many surgeons may choose to use one for comfort and safety during the operation, but technically they could do it without even touching the ventricle. So this means, as the surgeon did not touch the ventricle, all the effects we see after the Fontan operation are secondary phenomena and are due to the new boundary conditions. And now this is an extremely, extremely important concept. So, in a nutshell, the essence of Fontan surgery, it is extracardiac surgery, vascular surgery, and the ventricle is left untouched. There are a few exceptions, actually 5. Sometimes the surgeon may choose to go for a short cardiac arrest, for instance, to perform a sepectomy, but it is exceptionally he will do that at the Fontan surgery itself. He may choose to use some cardioplegia if he has to do a repair of the valve, or also if he has to resect a stenosis somewhere in the ventricle. But again, this is very exceptional nowadays that the surgeon will do that at the time of Fontan. It is also exceptional that we will unload the ventricle to such a degree that we will come in the neighborhood or below the closing volume. I will come back to that in the next slide. And I will say that that was a frequent problem in the 80s, but since the 90s, it has become very exceptional. And then last but not least, the Fontan state indeed will impose some conditions. The boundary conditions of the Fontan state will all result that the compliance the compliance of the ventricle will significantly decrease. And that will be very important. First, a word about the closing volume. You all know that as you unload a muscle or the ventricle, so as there is less initial stretch, you will have less contractility. And this point does not go through zero. It will have here a minimum volume. So a ventricle needs a minimal volume in order to have a minimal contractility. We all know these graphs from our pre-med school. And this was a typical situation in the 80s when we went from a double shunt, so multiple large shunts, they did result in huge ventricle. So if you took away those shunts, there was significant unloading, as surgeons nowadays still may see after they repair significant aortic regurgitation or a mitral valve. They end up with a ventricle that is collapsed and hardly has any pressure. Again, this did exist in the 80s. Nowadays, it has become extremely rare because we never go again from double shunt to Fontan. The second thing I mentioned was that with time, you see here early after Fontan, late after Fontan, the diastolic pressures significantly do increase invariably in all the patients. Another basic question that we as cardiologists and as so-called hydrodynamic specialists must be very much aware of is, if there is somewhere an obstruction, how can you improve the flow throughout the whole system? And that is a very general question, and there is a very general answer to that. If there is somewhere an obstruction and you want to get more flow through the system, there's always 3 ways. Either you push harder above the upstream, or you deal with the obstruction itself, or you pull downstream. Now, obviously, not all these solutions are equally efficient and easy. Typically, dealing with the obstruction will be the most efficient. Pushing harder upstream will be the easiest, and pulling downstream very frequently or almost invariably will be the least efficient of all the systems. Another very important feature is how to deal with multiple bottlenecks. Here you have an example of multiple bottlenecks. And in a fraction of a second, every single one of you will have seen where is the critical bottleneck. And I think we will all agree that if you alter or you change something at the non-critical bottleneck, not too much will change throughout your system. It is only when you will change the critical bottleneck itself that you will influence the flow throughout the system. So the basic concepts are, in a circuit like this, there is always only one critical bottleneck. And to be honest, it's the only thing to work on. Working on the non-critical bottlenecks is actually irrelevant and will have no benefit for the flow throughout the whole system. Very, very important concept. Now you're going to say, whoa, we come here with a ton of new concepts. That is not true. We have been applying these concepts for years, for decades, but usually it is so obvious that we don't do this basic thinking. For instance, in patients with a cardiomyopathy, we all know that the problem is over here at ventricular level. And so if you want to deal with this problem, as I said before, deal with the obstruction itself. So that means get inotropics and have the ventricle squeeze better. And if that doesn't work very well, push a little harder upstream so that you will force the ventricle, or decrease pulmonary systemic vascular resistance so you can pull in a little easier. The three variables. The same thing for pulmonary hypertension. The problem is over here. So the most efficient is give vasodilators to get rid of the resistance. If that doesn't work, push harder in your right ventricle. If that doesn't work, pull harder downstream. But I mean, pulling with the ventricle, as you all know, is not that easy and it's very limited. Similarly with mitral stenosis, the problem now is over here. So the most efficient way to deal with mitral stenosis is deal with the valve and make sure it opens well. If that doesn't work, increase the pressure in the left atrium. If that doesn't work, pull harder at ventricular level, but that is easier, much easier said than done. Now, what about the Fontan circuit? Well, as we mentioned already, the surgeon did create over here the dam, and we all know what the fenestration does. The fenestration will decrease the congestion over here, and it will increase the flow over here. So it will neutralize the effect of our dam. Now, that is exactly the definition of a bypass versus the critical bottleneck. A good bypass will determine where the critical bottleneck is, and so the critical bottleneck in this circuit will be between both ends, both points of your bypass. So the critical bottleneck consists of the connection itself, the surgical connection, and the large pulmonary arteries. The pulmonary vascular resistance, where we can have flow collision collaterals. Here the pulmonary veins, and then last but not least, the pulling force over here from the left ventricle. As mentioned before, you can have a bypass which can attenuate the problems of congestion and low output. Now with this circuit, how is the relationship between cardiac output and pulmonary vascular resistance? Well, in a normal person with a biventricular circulation, the pulmonary vascular resistance may increase to even high levels because this patient has a right ventricle. And so as the pulmonary vascular resistance will increase, the right ventricle will squeeze a little harder and you will see no change. You only will see the change after 10 or 20 Wood units. What is the case with Fontan patients? Well, every intensivist dealing with Fontan patients early after the operation will know that. If he increases pulmonary vascular resistance by, for instance, increasing the PEEP, cardiac output will go down. And reversely, If he decreases pulmonary vascular resistance in the patient with the ventricle, cardiac will go up. However, it may be limited in patients with a very, very poor ventricle. Similarly, what is the relationship between cardiac output and ejection fraction in the patient? Well, we know in normals, and every clinician that is caring for patients with congestive cardiomyopathies will be able to confirm that as contractility decreases, it is only when you go below a certain level that indeed you will see that the cardiac output goes down. Same thing for Fontan patients. So a Fontan patient with very good pulmonary vascular resistance, I mean, he will have a slightly lower output at rest. And as ventricular function decreases, for a long time, you will almost see nothing. But of course, as ventricular function decreases below certain levels, it will go significantly down. And similarly, as pulmonary vascular resistance increases, this is the way the graph will behave. Now, imagine a patient over here with output 50% of what you would like, and you would love to increase his cardiac output. Well, this cartoon then explains that increasing contractility will give no change in output. The only way to increase significantly the cardiac output is work on pulmonary vascular resistance. And that is a feature that we have seen and has been proven over and over and over again in the 80s and in the 90s. What are the changes with time in a Fontan circuit? Again, our basic cartoon. And so what happens is, first of all, the diastolic pressure will increase. We see that invariably in all the patients. And also in some patients, pulmonary vascular resistance will increase. So the primary changes that we see occur in Fontan patients are vascular resistance and diastolic pressure that increase. The secondary changes are then, by definition, as both these increase, the congestion will increase, output will decrease, ejection fraction, which is very preload dependent, will decrease, systemic vascular resistance also will decrease. So it's very important to understand what is pulmonary vasculature and how does it behave in time. Here you see a cartoon where it is reflected what a pulmonary vascular resistance will do in a normal person. And there's few data available, but I mean, some data will show that at older age, 70s and 80s, indeed, pulmonary vascular resistance will increase as everything stiffens up. Now, in Fontan patients, the good Fontan patients, our best Fontan patients, pulmonary vascular resistance will be low and will remain low for many decades. And indeed, my oldest patient now is in her 60s, and we see there things going wrong with pulmonary vascular resistance increasing and diastolic significantly increasing. What with patients with moderate pulmonary vascular resistance or even higher pulmonary vascular resistance? Well, we will see that they will increase their pulmonary vascular resistance much faster. And this patient, for instance, probably never should have gotten a Fontan circuit in the first place. That is one of the lessons we learned in the late 90s, early in the century. Now, the key feature is that we have been trying to look for medication or maneuvers in order to keep the pulmonary vasculature as low as possible, but we're still not there yet. So when you talk about patients with a single ventricle, I think by now everybody will have understood that pulmonary flow is extremely important. So it is very important also to understand the structural abnormalities, the structural and functional abnormalities of the pulmonary arteries. Now, pre-Fontan, we do sometimes quite a few nasty things to those pulmonary arteries. There can be stenosis, distortion, kinks. There can be loss or exclusion of the large vessels. Some hypoplasia may persist. We may cause some pulmonary vascular disease, or there may be some external compression. That is before the Fontan. The Fontan state itself is also not so very nice for the pulmonary vasculature, because there is absence of pulsatility with a very steady and low flow. And we now know that that is very bad for the endothelium. There may be absence, there is absence usually of high flow, high pressure, and much less recruitment in these patients. So you may lose some apical segments. There may be an inhomogeneous distribution of hepatic factors. Collateral flow will not improve the things. And also there may be circulating vasoconstrictors or vasodilators. Now, we have been concentrating on pulmonary vasodilators the last couple of years, but already based on this list, you can predict that any vasodilator, pulmonary vasodilator, will have a limited effect. Why? Because it will only influence these two features, the pulmonary vascular disease and the lack of vasodilators. All the other items, pulmonary vasodilators, will have no influence whatsoever. So don't put all your money on pulmonary vasodilators, because there are very, very many features it won't work. Another very important concept is that you should realize that every ventricle in a patient has a history. Here you have the pressure volume loop of a normal left ventricle of a normal person. Now, already during fetal life, if you have a single ventricle, for instance here, a single left ventricle in a patient with tricuspid atresia, it is obvious that this ventricle now has to do the work of both the right and the left ventricle of the normal patient. So this will be the pressure volume loop of a fetal patient with, for instance, tricuspid atresia. There is now a new relationship between the ventricle and the body surface area. After birth, typically the volume load will increase because that single ventricle will have to provide blood both for the body and for the lungs. And so nowadays, this will become the new pressure volume loop, and the relationship between the ventricle and body surface area will be lost, because the pulmonary flow will be a much bigger determinant of ventricular size and ventricular growth. Now we go for Fontan, and then this is what happens. We unload the ventricle. The ventricle by then will be much bigger. It will be overgrown for the situation, but the preload is significantly reduced. And as we already discussed before, in time, the end diastolic pressure will increase, the stroke volume will decrease. And so in the long run, this will be the pressure volume loop curve for the Fontan patient. And now comes the issue. This ventricle, which was previously overloaded and stretched in this graph over here, due to the fetal and the initial shunt, after Fontan, it's actually chronically volume deprived. It is still big. I mean, it is big if you compare it to normals. It is either overgrown, but it is collapsed, deprived, or strangled. And so whether the word dilated is really appropriate to describe this ventricle, I mean, compared to a normal, it will be dilated. Compared to what it used to do or what it used to be, the word dilated is, I think, not appropriate. As would-be hydrodynamic engineers, we speak about pressure pumps and suction pumps without sometimes realizing what it really means. This is a typical example of a pressure pump, and every fireman will be able to confirm that this is the kind of pump they use to put out a fire. They have to push as hard as they can to get the water where it should be. However, if they run out of water, they need a suction pump to get water from a nearby lake or wherever, or a pool, so that they can get water in this pump. We as cardiologists, we are dreaming that our ventricle is a pressure suction pump, and that indeed does exist, but that is the graph of a pressure suction pump. In reality, if we look at our Fontan ventricles, the pressure graph looks much more like that. And so the suction component is at least attenuated to see it nicely, or even non-existent if you look carefully at the graph. And the point is, if truly the Fontan ventricle would be a pressure suction pump the way we would love it to be, there would be no Fontan problem. The problem is that the suction component of the ventricle is quite different. So here, the other concept which has become exceedingly important is, why does the end diastolic pressure increase during time? Now, there are several factors. For instance, aging is one. We know that an elderly person will have a stiffer ventricle than a young athlete. And can we slow it? Can we prevent it? Well, we don't know. Nothing has been proven on these issues. We are still hoping it will. One thing is for sure, if you have a muscle and you don't stretch it, it will stiffen up. Now, translated to the ventricle, this means that the less you stretch a ventricle, the faster it will become less compliant. And so then it becomes important, what is the degree of overgrowth of the ventricle? And that is determined by the initial shunt or leaky valves. How much will you deprive the ventricle during the Fontan state? And that will be dependent on how much blood goes through the lungs, how much blood goes through your Fontan portal system. And if there is really no stretch whatsoever, we know every athlete will be able to confirm you that his muscles will stiffen up much, much faster, and he will be not as performant as you want it to be. Now, stretching in a normal person is done by exercise, and technically, I mean, you also could do it by an RVAD. Factors that will decrease the end diastolic pressure, as I already mentioned, acute stretch as with exercise, and theoretically, experimentally, you could consider other things, but as you see, they are extremely, extremely invasive. Or you could do it chronically, and there again, exercise, an RVAD, conversion, making shunts, allowing some regurgitation somewhere could be helpful. Drugs, we dream about good lusitropic drugs that would reduce compliance or enhance compliance. However, so far we have none. Another very important basic concept is, how do we think about cardiac output and which factors do we use in our formulas? Now, the different factors are preload, heart rate, afterload, volume, contractility. What can we say about that? Well, in typical cardiology, the preload to the ventricle is more or less unlimited, especially in congestive heart failure. The word congestive already says it. The left atrium usually is bulging and provides any preload that the ventricle would love to have. What about heart rate? Well, there are different factors that will determine the heart rate. The sinus node itself, the hormones, circulating catecholamines, and last but not least, the Bainbridge reflex. So if you have a large venous return, automatically the heart will accelerate. Afterload, if it stays within limits, usually it will not influence cardiac output or stroke volume to a great limit. And then we apply our formulas. The stroke volume is determined by end diastolic volume and ejection fraction. We know that all these are the independent variables, so this is cardiology at its best. The cardiac output, you can describe it, stroke volume times heart rate, or this formula over here. And so we all know as cardiologists, if you give more preload, you will get more output. If you give a higher contractility, you will get more output. If you increase the heart rate a little bit, even that will increase the output. In Fontan patients, things look completely different. So for instance, what do we know about the preload? Well, the preload is limited. That's the definition of a Fontan. The surgeon did create an upstream dam. And so what comes through the dam will determine the preload of the ventricle. By definition, it is limited. What do we know about the heart rate? Well, the sinus nodes sometimes may be damaged. The catecholamines and the other hormones will be slightly changed, but especially the Bainbridge reflex will be extremely attenuated. You will never get the venous return in a Fontan patient as you have in a normal. So already you can predict that the heart rate will be blunted and attenuated. The afterload, typically we think that the afterload in a Fontan circuit is increased. However, you should realize that typically such a ventricle will push a smaller volume against a lower pressure. So almost by definition, although systemic vascular resistance will be increased, the afterload usually will be decreased. Now, the independent variable is over here, the preload. And so that means the cardiac output in a Fontan patient actually is the ventricular preload. This formula still stands, but now it is full of dependent variables. The ejection fraction is extremely preload dependent. The end diastolic volume is extremely preload dependent. So varying these, influencing these, will not influence, I mean, first of all, you must be able to do so, but it will not significantly influence the cardiac output, because preload now is determined by this: the driving force throughout the pulmonary vasculature, and then the resistance in the whole circuit. And so what do we see in time? Well, in time, pulmonary vascular resistance may increase, the filling pressure will increase, the central venous pressure will increase. This will result in a increase, and so cardiac output will also decrease. Now, this formula is extremely important because it means that if you want to influence this circuit, and this is the formula that with the independent variables that will determine output, it means that if you do not measure at least these variables, you will not know what you're doing. You may be measuring other variables, but it will be secondary changes or even tertiary changes. As long as you don't change any of these, you will do nothing in a Fontan circuit. And that is, again, very, very important if we are considering drugs or maneuvers, and that drug or maneuver will not influence either of these four, you will see no effect in the system, especially concerning cardiac output. Cardiologists, we did invent a very nice word, chronotropic incompetence, in Fontan patients. And it was based actually on this graph, where heart rate during exercise is expressed as a percentage of the maximal workload. And indeed, if you express it this way, you see that these are the normals, these are the Fontans, and invariably the heart rate at maximal exercise capacity expressed as a percentage of its maximal is lower. But is that the correct way of representing this? This here is a cartoon of a very early study I made in the 1990s. And what you see over here, that if you represent heart rate in function of exercise capacity, of exercise level, that except for the resting value, nearly all the, at every exercise level, the heart rate was higher than normals. And this has been confirmed over and over again. Here, for instance, in a study we recently published in an animal model of Fontans, where this sheep over here got a Fontan circuit. And so we were able to compare its heart rate during exercise with biventricular heart versus Fontan state. And as you see, again, the same graph, at rest somewhat lower, but at every comparable exercise level, the heart rate was higher. We also did that in patients where we imposed a treadmill on our Fontan patients and determined cardiac output, many variables. Very interesting paper to go and look at, where you could see that end diastolic volume would decrease during exercise, stroke volume decreases, especially when you compare it to normals. But most importantly, if you look at the heart rate and you express it versus the workload, the heart rate in Fontans at every exercise level was higher. Also, if you express it as oxygen consumption. So how come that word of chronotropic incompetence became so widely accepted? Well, it's because of the kind of representation. to be very honest, I don't know any hydrodynamic or mechanical engineer that will compare two engines by comparing them expressed in maximal of their exercise capacity. If you want to compare two engines, you compare them at comparable levels. And so at every comparable level, Fontan patients are faster than normals. As a matter of fact, the term chronotropic incompetence would suggest that if you would pace the patients faster, they would do better. Well, we all know that is not true. If you would make them faster, you may kill them. And so instead of speaking about chronotropic incompetence, we should speak about chronotropic protection. That word is probably much more appropriate. In another cartoon, here you see what the stroke volume does if you go for atrial pacing. First the cardiac output. If you take a normal and you go for atrial pacing, we know from the cath lab that you may increase the output 10, 15%, something like that. And then when you go to very, very high heart rates, the output will decrease. What does that mean for the stroke volume? Well, a normal ventricle will have stroke volume reserve, but as you go too fast, there will be a filling problem, and indeed stroke volume, and after a while also cardiac output will decrease. What happens in Fontan patients? Well, as you start pacing a Fontan patient, there will be no change in cardiac output, and as a matter of fact, already at relatively low heart rates, the cardiac output will decrease. Why? Well, there is no preload reserve. So as you speed up the heart rate, as you increase the heart rate, stroke volume will immediately go down, resulting in no increase of cardiac output. We all know that heart rate disproportional to preload is detrimental. We know that from mitral stenosis. We know that from mustards with obstruction, and it has been confirmed over and over again already in Fontan patients. So, in a nutshell, the Fontan dam, when we create it, it consists of the connection and the pulmonary vascular resistance. This will create upstream congestion and decreased low flow. The low flow will increase, negatively influence both pulmonary vascular resistance and the anti-diastolic pressure. This will make the congestion and the low flow worse. This will result in multi-organ failure, and then we have a complete vicious circle. So the effect of the damming, it is very important to consider the primary effects. As I said, it is the upstream congestion and the decreased low flow, and all the rest are the secondary effects. The effects of the congestion, the effect on the pulmonary vascular resistance itself, the effect of the ventricle both in systole and diastole, but also the effect on systemic vascular resistance, collaterals, humerals. What is important that the PVR and the suction can enhance the primary effects, and then in return, those primary effects will further enhance the secondary effects, and again, we have our vicious circle. So I think that by now, everybody will have understood that the secret of a good Fontan circuit is to have a very good dam, a competent dam with a low resistance, and that means pulmonary vasculature at its best. Now, in order to understand pulmonary vasculature, we know in normals that there are two phases in normals for pulmonary vasculature. That is fetal life with very limited flow, and then postnatal life where at rest it will be 100% of normal. And that is the main driving force for the pulmonary vasculature, the chronic output. Now, in patients with a single ventricle, instead of having two phases, there will be four phases. There is the fetal life, and then there is the initial shunt, typically with an overflow to the pulmonary vasculature, and that is then the time where you can have some catch-up growth. When we go for a Glenn and we take down the shunt, almost invariably the flow to the lungs will be decreased, usually at half of normal, and then the patient will outgrow his Glenn shunt. We will go for the Fontan that will increase the amount of blood going to the circuit, and then we hope that it will remain stable like this. So 4 phases: fetal, initial palliation, Glenn, Fontan. What we have to realize is that the initial palliation is the only period where there will be catch-up growth. And so at the end of that initial palliation, we need to have low pulmonary vascular resistance, absence of hypoplasia, no pulmonary vascular disease, and no asymmetry. The thing is that things can go wrong. For instance, in a patient who has a poor shunt, we will see little overflow over here. In other words, little catch-up growth that will result in early cyanosis. And so the clinician may then decide over here to go for an early Glenn by necessity. By doing so, he will decrease the flow. Don't expect any catch-up growth at this low volume. And when you go then to a Fontan, you see that you end up with a bad Fontan and a decreasing result in the long run. So what we now cardiologists have been doing the last couple of years is try to find medications or tools in order to get this line over here. But what you have to realize is that this bad result actually was caused by the poor initial shunt. And for me, the major decisions, the most important decisions that you can make in a patient with a Fontan operation is in order of importance. First of all, the initial palliation, the quality of the procedure and its capacity to induce adequate pulmonary growth. If you have a good initial shunt, finalizing the Fontan circuit will be a home run. If you have a bad initial shunt and you get distorted, crooked pulmonary arteries, whatever you're going to do, whoever is going to be the Fontan surgeon, he will end up with a poor, mediocre result. The second most important decision at Fontan, in Fontan management is the timing of the Glenn. Some centers will go for a Glenn, for instance, when the patient goes to 4 months or 5 months or 6 months or something like that. But you have to realize that once you go to Glenn, you stop any catch-up growth of the pulmonary arteries. And if there is any asymmetry, the asymmetry will increase. I mean, you all know this experiment over here that if you give flow to a system, I mean, the smaller balloon will become smaller and the bigger balloon will become bigger. The same thing in lungs. So let me come back to this graph. At this point, instead of going to the Glenn, you could also choose to enhance or improve or augment the flow so that you can get again a phase of catch-up growth. You may delay the period of the Glenn, but at the end, by the time you go to Fontan, you will have had a nice growth of your pulmonary vasculature, and you may end up with a much better Fontan than initially was planned. Now you say improving or enhancing flow through the pulmonary arteries. Indeed, many centers will be very, very reluctant to go for a second shunt, but sometimes it is possible to augment the initial shunt. For instance, the Gore-Tex that we use for all our shunts, it can be stent expanded, and you can give that way a second wind to almost any Gore-Tex shunt. Here, for instance, a patient that was born prematurely, got a very small shunt, and at 4 kilograms, it had reasonable pulmonary arteries. However, we are keen to get as much growth out of those pulmonary arteries and out of the shunt as possible. So we chose to stent augment this shunt, ended up with much nicer and bigger pulmonary arteries, maybe even slightly overgrown, but this patient ended up with a very nice Fontan circuit. Similarly, here a patient, and there are slides that I borrowed from Yves Dudechem, who is now in Washington. Here a patient that he did in Melbourne. After the Glenn, he saw that there was a very nice right pulmonary artery, but a small hypoplastic left pulmonary artery. Now, those who believe that with this Glenn, that there will be catch-up growth of the left lung, I mean, if you believe that, then you believe anything. I think most people with experience will know that there will be further good growth of the right lung and the left lung will be left like this. So by the time you go to a Fontan, you end up with a Fontan actually on a single lung. So what did Eve decide to do over there? He did divide both lungs, put a big shunt to the left pulmonary arteries and forced it to grow. And that allowed him to finalize then the Fontan circuit with a good, reasonable pulmonary artery. I mean, it's still not perfect. It's still a little worse than the right, but I mean, at least this patient has now both lungs to work with. So the key issue is, how do we get flow through the critical bottleneck? And as I said, there is 3 ways to do it. Either you push harder, you deal with the bottleneck itself, or you pull after the bottleneck. Pushing harder, that means the patient can use his muscle pumps, and that is the way for the patient to increase his cardiac output. Exercise, use his legs, use his quadriceps, that will push blood into its cave veins and will push it through the lungs. We could do it with a mechanical pump, for instance, an RVAD. You can also deal with the bottleneck itself, and so we know all the tricks over there. Optimize the connection, get rid of stenosis, get rid of compression, work with vasodilators, but as I said, don't expect the spectacular result because many lesions are not influenced by these vasodilators. Work on respiratory pattern, recruit with exercise as many vessels as you can, and anticoagulation may have a role over there. And then the last one, and probably also the least important in this case, enhanced ventricular suction. We don't have drugs. We would love to have them, but we still don't. Stretching the ventricle, making it a good muscle like every athlete would do, I mean, is easily said, and but very difficult to do. By the way, when looking at this problem, what was the solution of evolution? There is actually a few animals that function like a Fontan, but these animals have not become or remained very competitive. Evolution did provide a solution that is much, much more performant, and actually that is the right ventricle. This is the solution by millions of years of evolution, or for some of you, it is a solution of God. And so we cardiologists, we have to remain a little bit humble. This is probably the best solution. All the others will be less. So the most important thing of managing the problems is avoid the problems, and that is by getting optimal building blocks. Get your best possible lungs. That's where you have to invest your money. And obviously you need to have a good ventricle with especially low filling pressure, not too oversized, and a good systolic function. But there may be a problem between getting good lungs and a good ventricle. But then give, please, priority to the lungs. Treating it, I just said that in the last slide. And now my very last slide. What was I taught and what do I now teach? Well, nowadays, I teach that a Fontan operation is not cardiac surgery. It is non-cardiac surgery. It is actually vascular surgery. And that has the important implication that when you see that the ventricle is big, overgrown, and dysfunctional, actually there are secondary phenomena to the boundary conditions, the previous and the new boundary conditions of the heart. There's a big difference between the increased systemic vascular resistance that all our patients will have, but usually the decreased afterload, because afterload is a very preload dependent phenomenon. You should not speak about heart failure because the surgeon even didn't touch the ventricle. It is much more appropriate to speak about circulation failure. And by the way, our friends, the pneumologists, were smarter than we are. They speak about respiratory failure and they speak never about lung failure. That leaves the option, if you speak about respiratory failure, the problem can be anywhere at the trachea, the bronchia, the lung, the pleura, the muscles, the ribs, whatever. We should have the same habit of speaking about circulatory failure because that keeps your mind open for all the possibilities. We always should go and look for the critical bottleneck, which now we know is that new portal system. It can be either connection, the pulmonary vascular resistance, or the ventricular pull. Obviously, this formula is correct, but it is full of dependent variables. You need to go to the formula with independent variables. And if you set up a study, at least you have to measure these or you won't know what you're doing. And if you're looking for a drug or a maneuver that will improve a Fontan operation, if it doesn't change any of these four numbers in the good direction, you will not be doing anything good in that Fontan circuit. Instead of concentrating on treating the failure, you should try to go avoid it. And don't forget, when you treat it, there is only one critical bottleneck in a circuit by definition. General lessons, basic physiology, as always, does matter. Be aware of the difference between primary and secondary effects and the dependent and independent variables. We should learn to accept good studies, even if they have negative findings, which we don't like. And please always be critical and don't believe your own wishes, as we have done for many decades during Fontan physiology. I thank you for your attention.